Good afternoon, everyone. Interstitial pneumonia is an umbrella term for over 200 rare diseases that primarily affect the interstitium, small airways, and alveoli. So, today we discuss the update of the International Multidisciplinary Classification of the Interstitial Pneumonias and ERS ATS statement. And I am your presenter for today, Dr. Neha Sharma. The 2013 behavior era. This was formal recognition of NSIP as a major pattern, and PPFE was added as an eighth entity. Greater recognition was given to the importance of disease behavior. And today we discuss the 2025 update, the integrated or the multidisciplinary approach era. It incorporates both the idiopathic and the secondary causes of interstitial pneumonia. A quick review. The 2025 approach focuses on the interstitial versus the alveolar filling pattern, and it aims to integrate both the secondary and the idiopathic etiologies into a single continuum. The clinical rationale being that at presentation, mostly the etiology is unclear, and this update classification aligns the morphological pattern directly with the underlying anatomy affected. This allows for any new causes to be added dynamically without disturbing the framework. This classification unified the idiopathic and the secondary causes into a continuum. There is formal division between the interstitial and the alveolar filling disorders. There is addition of new terminology while eliminating the outdated terms. And there is formal recognition of the diagnostic confidence threshold to facilitate strict reporting and management universally. The fundamental anatomical split. The 2013 document subcategorized the idiopathic interstitial pneumonia as chronic fibrosing, smoking related, and acute and subacute subtypes. Now, the current document advances this while still highlighting the importance of disease behavior. Firstly, there is this separation into the interstitial and the alveolar filling disorders based on the predominant location of the lung injury, recognizing that pure interstitial or pure alveolar disorders are uncommon. Now, the interstitial disorders are further subgrouped into fibrotic and non-fibrotic types, which is crucial for patients with NSIP or BIP patterns that can present across this spectrum. The alveolar filling disorders are further subgrouped by the type of cell or fluid occupying the alveoli. This updated classification has biological, prognostic, and therapeutic implications. Quickly going over the three major terminology changes and their rationale. The acute interstitial pneumonia term is now replaced with idiopathic diffuse alveolar damage, the rationale being AIP was imprecise. Acute presentations exist in other pneumonias. Idiopathic DAD anchors the pattern precisely to its histologic reality. Desquamative interstitial pneumonia is replaced with alveolar macrophage pneumonia, the rationale being DIP is pathologically inaccurate. The pattern is not driven by pneumocyte desquamation, but by airspace macrophage accumulation. Then the hypersensitivity pneumonitis pattern is replaced with bronchiolocentric interstitial pneumonia. The rationale being this separates the morphological pattern, that is BIP, from the clinical diagnosis, that is HP. BIP also encompasses CTD-ILD, aspiration, and drug-induced ILD. These changes in terminology aim to reduce the confusion and better reflect the underlying pathology of these diseases. There is often uncertainty in the diagnosis of interstitial pneumonia given the absence of a pathonomic test for most diagnoses. A previous working group addressed this issue, labeling patients with diagnostic confidence more than 90% as confident diagnosis, 51 to 89% as provisional diagnosis, and the absence of a leading diagnosis with 50% confidence interval representing unclassifiable ILD. The 2013 classification primarily categorized the patients according to the histological pattern, including 6 major idiopathic interstitial pneumonia, 2 rare idiopathic interstitial pneumonia, and unclassifiable interstitial pneumonia. A complementary disease behavior approach based on the anticipated clinical trajectory was also implemented. The 2025 classification presents a single system that incorporates all the interstitial pneumonia, combining the idiopathic and the secondary. Now, the master framework of the 2025 update. ILD suspected on the chest CT. Next, based on the predominant anatomy involved, interstitial or alveolar, and then further subcategorize. Although PPFE and DAD are not always predominantly interstitial in certain phases of the disease progression, this committee believed it most appropriate to place this in the interstitial disorder. The table from the guidelines characterizing the major radiological findings on the chest CT with the most commonly associated pattern. This approach continues to emphasize the distinction between pattern and multidisciplinary diagnosis. On chest CT, ILD findings, then again characterize them based on interstitial and alveolar disorders, and major patterns observed on the imaging, craniocaudal distribution, axial distribution, and some particular features. Again, similarly for the alveolar filling disorders, distribution, the density of abnormality, and associated features, and relating them to the most commonly associated diagnosis. Again, table from the guidelines relating the pattern to the most favorable associated diagnosis. The pattern is associated with the diagnosis and again incorporating both secondary and idiopathic diagnosis, signifying the multidisciplinary approach. This document recognizes the 3 main fibrosing patterns of interstitial pneumonia: UIP, NSIP, and BIP. Now, a quick glance on the clinico-radiopathological profile of these 3 major patterns before going into depth. UIP, the clinical profile, mostly presents in older males with a smoking history and has a high progression risk. Radiologically, subpleural lower lobe predominant, reticulation is seen, honeycombing, peripheral traction bronchiectasis. Pathological hallmarks: fibroblast foci, spatial heterogeneity is seen, and architectural distortion is seen. NSIP, mostly seen in younger females, CTD background, variable risk of progression. Radiologically, lower lobe predominant. Radiologically, lower lobe predominant, subpleural sparing, ground glassing without honeycombing. Pathologically, uniform alveolar wall thickening, no honeycombing or granulomas are seen. BIP pattern: no age or sex predilection, HP antigen exposure history is present. Radiologically, diffuse peribronchovascular component, air trapping, mosaic attenuation. Pathological hallmarks: airway-centered fibrosis, inflammation, peribronchiolar metaplasia. Now going into details of each of these patterns. UIP, usual interstitial pneumonia. UIP is radiologically defined as subpleural and basal predominant fibrosis with honeycombing without significant features suggesting an alternative diagnosis, such as cyst, mosaic marked mosaic attenuation, predominant ground glassing, nodules, or consolidation. Probable UIP has the same features but without honeycombing. Imaging patterns of UIP and probable UIP correlate strongly with the histopathological features of UIP, thus allowing a confident diagnosis of IPF without lung biopsy in the appropriate clinical setting. Like we just read, older males, mostly with a smoking history. The hallmark pathological features include subpleural, paraseptal predominant interstitial fibrosis with temporal and spatial heterogeneity, abrupt transition from normal to fibrotic lung, subepithelial fibroblastic foci, and honeycombing. Up to 25% of surgical lung biopsies from patients with UIP have areas of NSIP, reflecting extreme spatial heterogeneity. UIP is the pathological hallmark of IPF, but can also be seen in other secondary causes such as CTD-ILD, fibrotic HP, asbestosis, particularly in more advanced disease. A quick word on how to differentiate them. CTD-UIP is often associated with sharply demarcated lower lobe honeycombing or exuberant honeycombing. Associated patulous esophagus, mixed pattern of lung injury, including organizing pneumonia, pleuritis, is also suggestive of CTD-UIP. HP is often suggested by subtle findings of airway-centered abnormalities. This is the CT imaging of UIP pattern. Honeycombing can be seen with subpleural and basal predominance. Some mild ground glass opacities are also seen. And this is a magnified view of the honeycombing. Now, the NSIP pattern, non-specific interstitial pneumonia. It encompasses a spectrum of non-fibrotic to fibrotic patterns. It most often presents with underlying causes such as CTD or drug toxicity, is sometimes seen in fibrotic HP or following cryptogenic or secondary organizing pneumonia, and is rarely idiopathic. Based on a recent systemic review, fibrotic NSIP is the most common ILD pattern in CTD, excluding RA associated ILD, where UIP is slightly more common. CT findings typically show lower lung predominance, ground glass, reticular abnormality, traction bronchiectasis. Approximately half of the fibrotic NSIP cases have relative sparing of the subpleural lung. This is a key differentiator from the UIP. As fibrosis progresses, the lobar volume loss increases, traction bronchiectasis and bronchioliectasis extend to more proximal airways, and reticular abnormality may increase. On pathology, there is diffuse uniform alveolar wall thickening, spatially homogeneous presentation, which is unlike UIP, and there is lack of granuloma or fibroblastic foci. This is the CT of non-fibrotic NSIP showing lower lung predominant ground glassing, minimal reticulation without traction bronchiectasis or other signs of fibrosis, and there is subpleural sparing. Again, CT of the fibrotic NSIP, lower lung predominance, reticular abnormality with traction bronchiectasis. Subpleural sparing is present. There is bilateral lower lobe volume loss with posterior displacement of the right major fissure. Over here. Then the bronchiolocentric interstitial pneumonia. Many patients with interstitial pneumonia have a pattern of airway-centered disease. The classical CT features of non-fibrotic BIP include profuse, poorly defined centrilobular nodules reflecting the peribronchiolar inflammation and ground glass opacity with mosaic attenuation, the 3 density sign, that represents a component of small airway obstruction. CT features of fibrotic BIP are less well characterized but include ground glass opacities, reticulation, traction bronchiectasis, mosaic attenuation, 3 density sign, expiratory air trapping, often in a peribronchovascular distribution. BIP can have both inflammatory and fibrotic interstitial pathology. The histological features of Non-fibrotic or cellular BIP include chronic lymphocyte predominant inflammation around the bronchioles, while fibrotic BIP is characterized by bronchiolocentric fibrosis, often with peribronchiolar metaplasia in adjacent air spaces. Differentiating between the final diagnosis of HP and a working diagnosis of idiopathic BIP requires careful evaluation for a potential exposure. BIP is thus recommended as an overarching term to define the histological or radiological pattern of predominantly airway centered interstitial pneumonia, which can be seen in the settings of HP as well as CTD ILD, aspiration, or inhalational medicational exposure. The CT of non-fibrotic BIP, diffuse ground glass, central lobular nodularity without traction bronchiectasis or other signs of fibrosis. CT of fibrotic BIP shows diffuse axial craniocaudal distribution of the three density sign consisting of multiple regions of lung with increased, normal or decreased density along with reticulation and traction bronchiectasis. Now, the other interstitial patterns, diffuse alveolar damage. The CT findings include ground glass opacities. Often they are bilateral, patchy, and focal sparing is seen. Consolidation, which is most often dependent. Then traction bronchiectasis or bronchioloectasis. Extensive pulmonary abnormalities are there, bronchial dilatation early in the course of disease, which is a predictor of acute worsening and increased mortality. DAD presents with acute or subacute respiratory distress, and it often requires hospitalization, has an increased mortality. It is sometimes reversible, but can evolve to irreversible fibrosis in up to 61% of prolonged cases. Then PPFE. The radiological hallmark is biapical subpleural parenchymal fibrosis with pleural thickening. Fibrosis manifests as sharply demarcated, dense consolidation, traction bronchiectasis, architectural distortion, and reticulation in subpleural distribution. PPFE is included as an interstitial pattern, but it also has substantial component within the alveoli and the distal airways. Then LIP is a part of the spectrum of reactive pulmonary lymphoid hyperplasia. LIP is very rarely idiopathic and mostly occurs secondary to CTD, especially Sjogren syndrome, SLE, RA, immunodeficiency, chronic infection, HIV, Epstein-Barr, human T lymphotropic virus, or other systemic immune disorders. CT typically shows bilateral ground glass opacities that are usually diffuse but may be patchy. Randomly distributed thin wall cysts occur in up to 70% of the cases. The architectural extremes, DAD and PPFE. DAD is acute fulminal onset, diffuse ground glass opacity, septal thickening. Pathology shows hyaline membrane and organizing fibroblastic proliferation. PPFE, pleuroparenchymal fibroelastosis, upper lobe predominance, which is in stark contrast to UIP and NSIP, which have lower lobe predominance. There is dense subpleural parenchymal fibrosis, marked pleural thickening, and highly demarcated consolidations. The CT findings, DAD, diffuse ground glassing is seen, and the PPFE pattern, apical predominant. The alveolar filling pattern, OP, RBILD, AMP, ranging from focal to diffuse involvement. OP, organizing pneumonia. It has multifocal distribution, high density consolidation, typically reversible but leaves residual fibrosis. Cryptogenic, has low progression but high recurrence. Respiratory bronchiolitis associated ILD, subpleural or patchy fibrosis, macrophage accumulation causing the symptoms, strongly smoking related, part of the smoking related ILD umbrella. Alveolar macrophage pneumonia replaces the term DIP. It has a diffuse distribution, ground glass density on the CT, associated with smoking, CTD, and medications. Now, the alveolar filling patterns are caused by several types of cells and fluids that abnormally fill the alveoli and the distal airways. Common patterns, as we saw, are organizing pneumonia, RBILD, AMP, with rare patterns including acute and chronic eosinophilic pneumonia, lipoid pneumonia, and pulmonary alveolar proteinosis. Now, organizing pneumonia can be idiopathic or cryptogenic or associated with an underlying conditions, mostly post-infectious, CTD, drug-induced. The characteristic radiological findings are the multifocal peripheral consolidation, frequently displays the reverse halo sign. There is subpleural peribronchial consolidation, ground glass opacity. Pathology involves the intraalveolar loose fibrotic plugs, fibrinous intraalveolar balls. Behavior is reversible but carries a risk of residual fibrosis. RBILD. The CT shows prominent cysts that are frequently clustered and confluent, mostly in the upper lobe or mid-lower lobes. RBILD should be used for the morphological pattern on histology and imaging when the macrophage accumulation is the cause of symptoms, with smoking-related ILD being used as the umbrella term for RBILD and other patterns such as AMP when they are caused by an exposure to smoking. RBILD and other forms of SRILD are frequently incidentally identified in lung cancer resection specimens. The pathology is accumulation of lightly pigmented macrophages confined strictly to the air spaces, behavior related with active smoking. Alveolar macrophage pneumonia commonly manifest as ground glass on chest CT. Ground glass in AMP is more confluent than in RBILD and primarily present in the mid and lower lobe, with a peripheral predilection often associated with fine reticulation. Pathology: there is diffuse, pervasive accumulation of macrophages in the alveolar spaces. Differentiation bar, the spatial differentiation as I just told. RBILD is more bronchiolocentric and upper lobe predominant, while AMP has diffuse distribution throughout the entirety of the alveolar spaces. The combined and atypical patterns are frequently seen in patients with familial pulmonary fibrosis. Now, patients who have the combined patterns are often challenging to diagnose and manage. A careful multidisciplinary evaluation can often reconcile the apparent finding of different patterns being observed in different regions of the lung to suggest a unifying diagnosis and guide the management and prognosis. Combined patterns, UIP, PPFE, common in IPF but worsens the prognosis. NSIP, OP, seen in up to 60% of the idiopathic inflammatory myositis. Key principle: the most progressive individual pattern drives the prognosis and the management. Unclassifiable ILD, the definition is the inability to provide a specific diagnosis with more than 50% of confidence after comprehensive multidisciplinary diagnosis. The reality of combined patterns. Up to 50% of patients with PPFE findings also have a UIP pattern. NSIP plus OP occurs in up to 60% of patients with idiopathic inflammatory myositis. Diagnostic confidence less than 50% acknowledges cases with major discordance between clinical, radiologic, and pathologic findings or cases altered by previous therapies. This is a table from the guidelines highlighting the common combined radiological histological patterns and the associated key differential diagnosis, dominant patterns and their associated coexisting patterns with the most common differential diagnosis. The diagnostic approach and confidence funnel: more than 90% confident, highly specific features present, actionable for definitive treatment. While the real world threshold says that clinicians often use a 70% confidence threshold in IPF to support management decisions without pursuing invasive surgical lung biopsies. A quick word on the molecular advances in diagnosis. Serum biomarkers such as autoimmune serology, ANA, inflammatory markers, CRP, to detect the secondary drivers such as CTD, ILD. Transcriptomics integrates gene expression with machine learning to identify UIP signatures on transbronchial biopsies, which has a specificity of 88%. Then genetics focus on MUC5B promoter SNPs, telomere-related genes linked to rapid progression. The frontier, evolving the 2025 scaffold. The 2025 classification system is a dynamic scaffold as molecular and genetic markers move from the frontier into the standard practice. The MUC5B promoter, telomere genes, RNA signature genomics, photon counting CT, optical coherence CT, representing the next leap beyond the HRCT limitations. The 2025 paradigm demands that we stop treating morphological patterns as final diagnosis. Interstitial pneumonia diagnosis requires relentless integration of multiple domains: the clinical, the pathological, radiological, and the molecular domains. A pattern is a clue, while the multidisciplinary diagnosis is the conclusion. Thank you. So, are there any doubts?
So thank you very much, Dr. Neha, for the wonderful explaining session once again. And this is the actually as per the guideline, as we are all seeing lots of ILD patients. So we have to know how to correlate between the clinical and the radiological patterns. And always first believe in yourself, then you discuss with radiologist. Don't go with the radiology report only. Always start with the previous pattern, UIP, non-UIP, or other is indeterminate. मतलब proven UIP, and then is other is probable UIP, then is a non-determinate. Then you will look down into this new classification and then correlate with the clinical features. Last week, I have seen the patient treated as that antisynthetase syndrome found to have HP with antisynthetase syndrome. That is a rare combination. So clinical features of that patient are both HP are more, and the HP prerequisite and the exposure is more with the pigeon than the antisynthetase syndrome. And the overlap between the two is difficult to differentiate. There is no one single article in the world that differentiate between the two. So you have to correlate clinically as well. And it was told by many of the our seniors and all the guidelines that you have to at the first time do ANA, RA, or anti-CCP only. That is not correct. First, you have to identify the pattern. It is CTD, ILD, UIP, NSIP, or any other. Then you have to go for the CTD panel. You can go for myositis, ENA, ANA, everything at one go. Because as you waste the time, patient is also wasting the time, and it may progress. Or you may diagnose it as PFILD, or you start the treatment at that time with the antifibrotic and the MMF. So it's first, ILD patient comes to you, it's first your responsibility to do the right diagnosis and the right treatment than others. You always think that no next hours or days can be waste for the patient, because generally patient present to us around with more than 6 month history or more than 1 month, 1 year history with lots of previous prescriptions. So this is from my side. Thank you very much. And if there is any questions, you can right now ask, or you can put on our group.
Sir, we have one question from Dr.
Okay.
Garima. What
Yeah.
pattern is seen in antisynthetase?
Anti-synthetase syndrome, the mosaic attenuation, that BIP pattern, that already Dr. Noha told that it is seen in HP and the CTD-ILD. So this is the common pattern we have in anti-synthetase syndrome. Centrilobular nodules with ground glass, mosaic attenuation with air trapping, and the three density sign pattern, which you used to see commonly. It is now not so rare. That is rare when I was studying 15 years ago, that it is not so rare.
Yes, sir.
Any more question? Okay, Dr. Neha, thank you very much for this wonderful class again.
Okay. Thank you, sir. Now we ending.
Okay. Okay.